Bismillahirrahmanirrahim. Worthy panelists, honorable guests, and my dear fellows, Assalamu alaikum. On behalf of organizers of HAEMCON2021, under the esteemed leadership and guidance of our chairperson, Professor Nuzhat Mushahid, and President Pakistan Society of Haematology, Major General, retired Professor Parvez Ahmed, Hilal-e-Imtiaz Military, I welcome you all to the very first and unique learning experience, Virtual HAEMCON 2021. I am Major Dr. Sunila Tashfeen, Classified Hematologist, and I will be the moderator for this scientific session 3, which is on red cell disorders. Let me introduce the panel members of this session. Our first panel member is Professor Chaudhry Altaf Hussain, Sitara-e-Imtiaz Military. He is a graduate of Army Medical College and completed fellowship in hematology in year 1999. He has performed his duties as consultant hematologist at various hospitals, and he is a pioneer to establish auto transplant facility and cryopreservation at National Institute of Bone Marrow Transplant Center. He has also worked in Armed Forces Institute of Transfusion and developed massive transfusion protocol in disaster. At present, he is Principal Medical College at CMH Institute of Medical Sciences, Bahawalpur. Sir, we are honored to have you chairing this session.
Thank you, Thank you.
Our second panel member is Associate Professor Dr. Saima Farhan. She is a consultant hematologist and Associate Professor at Children's Hospital and Institute of Child Health, Lahore. She has also served duties of General Secretary of PSH for 2 years and also has been selected twice as Executive Member of PSH Council. Madam, we welcome you to this session as a panel member. Our third panel member is Associate Professor Dr. Ayisha Imran. She is Associate Professor at Central Park Medical College and is actively involved with undergraduate and postgraduate teaching. She is also Executive Member of PSH and Hematology Faculty Member of College of Physicians and Surgeons of Pakistan. Madam, it's a pleasure to have you as a member of this panel. Ladies and gentlemen, we have 6 speakers and duration of this session is 130 minutes, which will be followed by question and answer and panel discussion. I will request all the speakers to adhere to their allocated time. Now I will invite Dr. Hina Jamshaid, first year resident clinical hematology in National Institute of Bone Marrow Transplant Center. The topic of her research is outcome of Rituximab in autoimmune hemolytic anemia, a single center study. Thank you. Over to you, Dr. Hina.
Thank you, madam. Assalamu alaikum. I am Dr. Hina Jamshaid, resident clinical hematology from Armed Force Institute of Bone Marrow and Transplant Center. Today I am going to represent a study that is response to Rituximab in relapsed refractory autoimmune hemolytic anemia. First of all, we will go into its background. Autoimmune hemolytic anemia is acquired hemolysis caused by the host immune system acting against its own red cell antigens. Rituximab is most frequently used second-line therapy in patients with relapsed refractory autoimmune hemolytic anemia. There is also an increasing evidence for its use as first-line treatment in autoimmune hemolytic anemia. The goal of the treatment is to improve quality of life by inducing sustained remission. Here is given the mechanism of action of Rituximab. It acts as anti-CD20 antibody, which causes lysis of the B cells by 3 mechanisms, that is antibody-dependent cell-mediated toxicity. Second one is complement activation, and third one is by apoptosis. The objective of the study is to assess response to Rituximab in patients with relapsed refractory autoimmune hemolytic anemia. The methodology consists of study design, population, data collection, and then assessment. The study was retrospective observational study that was taking place at Armed Force Bone Marrow Transplant Center, and the duration ranges from 2015 to 2018. The study will consist of total registered cases of autoimmune hemolytic anemia from 2015 to 2018 were number 112. Inclusion criteria consist of cases of autoimmune hemolytic anemia who received rituximab as second line or third line therapy at AFBMTC, and the patient received at least 2 doses of the rituximab therapy. The final cases included were 24. The data collected is per gender, age, baseline counts, chemistry, Coombs test, retic counts, response to therapy, frequency and severity of adverse events. The drug was given in 2 doses, 375 milligram and 100 milligram. 3 patients, that is 12.5%, received 375 milligram of the dose, and 87% of the patient received 100 milligram of the rituximab. Assessment done at 3 months, 6 months and 12 months after completion of the treatment. Response recorded using the following parameters, that is hemoglobin level, retics count, Coombs test, LDH. The results are given as under. 50% of the patients were male and 50% of the patients were female. Median age was taken as 27 years. 1.4% received rituximab as third line therapy, while 96% received the therapy as second line. These are the percentages of the doses. As I have said earlier, 12% of the patient received 375 milligram, while 87% of the patients received 100 milligram of the dose. Now, number of the cycles, 4.10% of the patient received 6 cycles of the therapy, 4.10% received 2 cycles of the therapy, while most of the patient received 91.60% received 4 cycles of the therapy. Now the response assessed is complete response, partial response and no response. Complete response was defined by normalization of hemoglobin to age and gender normal values and normalization of LDH with Coombs negativity. Partial response was defined by transfusion independence without normalization of hemoglobin, and no response was defined by hemoglobin value less than 8 gram per deciliter and requiring transfusion. The response was at 3 months post rituximab therapy. 50% of the patient did not respond to rituximab. 17% had partial response, while 33% of the patient had responded completely to the rituximab therapy. 1 patient developed pulmonary TB as a complication of the therapy. At 12 months post rituximab, response was sustained in 41.6% of the patients, while 2 patients relapsed, one at 6 months post rituximab therapy and the other patient relapsed at 10 months post rituximab. The response is given in a chart. Overall response was 50% and 50% of the patient did not respond. 17% of the response was partial response out of the overall response, and 33% responded completely to the therapy. Here is the international data. It is taken from a meta-analysis which was based on 20 studies. The patient included in it were 402 in number, and the overall response calculated from this meta-analysis was 73%. There are some other studies done internationally. Rodrigo et al. Done in 2014, the overall response was 45 to 66%. Renaud-Q et al. Done in 2014 showed 73% of the overall response, and Hill et al. Done in 2018 showed 60% of the response. Thank you.
Thank you, Dr. Hina.
Thank you, ma'am.
Dr. Zohra Farooq is our next speaker. She is second year resident in clinical hematology in Armed Forces Bone Marrow Transplant Center. Topic of her presentation is high sensitivity PNH clone testing in patients with hematological disorders. Dr. Zohra.
Assalamu alaikum. Thank you for the introduction. First of all, I would like to thank Pakistan Society of Haematology and all of its members of the community for giving me this opportunity to present myself and my preceptors, Lieutenant Colonel Ghassan Umair, and my colleague, Dr. Fayaz, who helped me a lot in preparation of this topic. Today we are going to talk about a very interesting topic, that is high sensitivity PNH clone testing in patients with hematological disorders. I do not have any disclosures. We all know that paroxysmal nocturnal hemoglobinuria is a rare acquired hematopoietic stem cell disorder. None of us was born with this disease. It's actually a somatic mutation in the pluripotent hematopoietic stem cells of phosphatidyl N-acetyl glycan class A gene located on chromosome X chromosome, results in a partial or complete absence of the membrane GPI anchors. We also know that there's quite a lot of heterogeneity in a patient presentation. Only just 40% of the patient presented with intravascular hemolysis, some with bone marrow failure and cytopenias, and others with thrombosis at unusual sites. Now comes to the diagnosis of the PNH. Initially in 1937 and 1939, sucrose lysis test and HAM test has been the standard way to identify PNH clone among RBCs. Later on in 1996, multi-parameter flow cytometry, which was discovered by the Hall and Rosie, was considered the gold standard for the diagnosis of GPI deficient protein CD55 and 59 on WBC and RBC in peripheral blood. It classified RBCs into three categories, that is type 1, mean normal cells, type 2, that is partially deficient, and type 3, total deficient. More recent test that is available is called FLAIR, that is fluorescent aerolysin. This is a protein that Rob Brodsky discovered basically from Aromonas bacteria, binds to GPI anchor rather than antibody against a specific target. The objective of my study is to detect a minor population of PNH clone in hematological disorders using a FLAIR-based assay. This is actually a single-centered descriptive cross-sectional study performed from July 2020 to December 2020 at Armed Forces Institute of Bone Marrow Transplant Center. Total 50 cases were included in the final assay. Our inclusion criteria is all the diagnosed cases of hematological disorders from all age group and from both genders. All others are excluded from the study, especially those who received a blood transfusion within the last 10 days. Data was collected according to the age, gender, baseline counts, retics, bone marrow opinion of the hematological disorder, FLAIR assay results, which include both panel, WBC and RBC were further classified into percentage of type 1, 2, and 3. Now coming toward the most interesting part of this study, that is the results. According to gender distribution, 70% were the male and 31% were the female, with the median age of 31 years. Indication for testing PNH are 36% are plastic anemia, MDS 12%, 16% were PNH, and others were 37%, which include those patients who presented with biocytopenia, thrombocytopenia, with hemolysis, iron deficiency anemia, and of course we are living in a COVID era, so those presented with the post-COVID pancytopenia, thalassemia intermedia. Among all these 50 patients, 42% were positive for PNH clone. And among 42%, the highest percentage were again aplastic anemia, 42%, PNH. With PNH disease is 40%, others are 15%, and MDS are just 5%. The most common hematological condition with underlying hematological condition is the aplastic anemia. Same as here, half of our aplastic anemia patient had a positive PNH clone. Among 6 of the MDS patient, 1 was found to have a PNH clone, and those who already has a clinical suspicion of a PNH came out as PNH, so it got 100% result. If we look at the clone percentage of the PNH clone, 76% of the positive cases had RBC and WBC, 15% had only WBC, and whereas 5% each were found for isolated neutrophil and monocyte. For RBC distribution, 68% of the total cases were type 1, means normal cell. Type 2 cell that is partially deficient were 18%, and 14 were completely deficient or type 3 cell. Now we discuss the maximum clone size that we got for each category, means for granulocyte, RBC and monocyte. The maximum neutrophil PNH clone size is 97.57%. The maximum clone size for monocyte is 97.91%. For type 2, it is 47.20%, and type 3, it is 37.3%. Studies from the Western countries, China and India, have shown detectable PNH clone in 40 to 50% of the patients with aplastic anemia and 10 to 20% cases of MDS. Previously reported data from Pakistan had remarkably low proportion of PNH. Incidence based on CD55 and 59 in aplastic anemia patient, and MDS was 4.7 and 0.8% respectively. In our study using FLAIR, a PNH clone was detected in 47% of the cases of aplastic anemia and 6.6% of the cases of MDS, which was quite similar to the international data. AFBMTC is the pioneer institute for using this technique in Pakistan, and research shows that FLAIR-based flow cytometric assay can detect small PNH clone up to 1% or even less in RBCs as well as in neutrophils and monocytes, which were previously undetectable by the flow cytometry for CD55 and 59. Thank you all.
Thank you, Dr. Samreen. Now I will invite Dr. Bushra Moiz to deliver a talk. She is a consultant hematologist and professor of pathology at Aga Khan University. Today, her talk is about serological diagnosis of autoimmune hemolytic anemia.
Assalamu alaikum and a very good evening. Thank you so much for giving this opportunity to me regarding, I'll be talking about serological diagnosis of autoimmune hemolytic anemia today. And in the next 20 minutes, I will discuss the serological workup, which we do in case of autoimmune hemolytic anemia. I don't have any disclosure for this presentation. So I'll be focusing on the serological workup of autoimmune hemolytic anemia, but it's always good to look at the subtypes because that will help us in understanding the various types and the way in which the workup is done in the blood bank. So autoimmune hemolytic anemia is a decompensated aquoid hemolysis caused by the host immune system acting against its own red cell antigens. There will be consequent complement activation also that can impact the clinical picture, and that is also an emerging target for the therapeutic approaches. Autoimmune hemolytic anemia is a rare disease with an incidence of 1 to 3 per 100,000 people per year. So being a rare, does that mean we don't need to know about this? No, because it is a life-threatening condition. We should know about it because it causes substantial workup that is required in blood bank, and that needs to be understood by us as a hematologist. There are various ways of classifying autoimmune hemolytic anemia, but the way in which I'm going to describe today is the one which is most commonly used, that is dependent on the optimal temperature in which the autoantibodies are reactive in the patient's body. About 67% of these antibodies are warm autoantibodies, 20% are cold, 8% are mixed, and about 1% are caused by the drug, which may be which we call as drug-induced autoimmune hemolytic anemia, which we'll see in the later part of discussion today. So regarding warm autoimmune hemolytic anemia, these are the antibodies that are reactive with red cells at 37 degrees centigrade. And as the name indicates, they are usually IgG. The warm autoimmune can be primary in 50% of the cases, which means they are idiopathic. We don't know why they happen, but they can be secondary as well to a number of various causes like lymphoproliferative disorders, immune dysregulations, SLE, rheumatoid arthritis, and HIV infection. We know from our normal physiology, we know from the normal physiology which we did in our medical schools that usually there is a system of autosuppression, and the clones are forbidden, that the body does not respond to its own antigen. There's a system of tolerance to a body's own cells that include the red cells as well. But there may be a number of pathological conditions in which the person starts forming antibodies against antigens. For example, if we see on the left side, these red cells, which are coated with antibodies, may be destroyed by the spleen through its macrophages, and that result in the formation of spherocytes. That's why the spherocytes are seen in case of autoimmune hemolytic anemia, which is warm type. But they can also be antibody-dependent cell-mediated cytotoxicity by the T lymphocytes and by the natural killer cells. If the red cells are heavily coated with IgG antibody, then complements can be activated, and that lead to the activation of C3. The C3b coated red cells are destroyed within the liver because they have the macrophages that destroyed with it. So that means we can understand that in warm autoimmune hemolytic anemia, the destruction of red cells is mainly confined to the spleen and to the liver. That is, it is extravascular hemolysis, and that will impact the manifestation and the clinical workup. The serological work are reactive at cold temperature. They can be cold agglutinin disease, which may be acute or chronic, or it may be paroxysmal cold hemoglobinuria. So considering the pathophysiology of cold agglutinin disease, the red cells which are coated with IgM antibody, they activate the complement, and these C3b coated red cells are destroyed within the liver, which means again it is extravascular hemolysis. But a little amount of intravascular hemolysis also occurs because of the activation of C5b9, which is the lysis complex. There are few things which we can remember because this can occur at any age, and it is usually the various viruses or bacteria, for example, Mycoplasma and Epstein-Barr virus, that lead to it activation. It is the IgM antibody mainly, because the name indicates it's a cold agglutinin disease, and typically the target is the big I or little I antigen of the red cells, and hemolysis happens mainly in the liver because the complement phagocytic system, or the phagocytes that have the C3b receptors, are present mainly in the liver. So it is again extravascular hemolysis. In contrast to cold agglutinin disease, the patients with paroxysmal cold hemoglobinuria have, as the name indicates, it's paroxysmal. That means it is an IgG antibody instead of IgM. But what does it do? It gets attached to the red cells in the circulation, in the peripheral circulation, but it gets activated inside the internal circulation at 37 degrees centigrade. But unlike cold agglutinin disease, it activates mainly the complement pathway, leading to the formation of C5b9 complex, leading to intravascular hemolysis. A little extravascular hemolysis can also occur when the C3b coated red cells are destroyed within the liver. This on the right side, I'm showing you few cartoons to help you understand that paroxysmal cold hemoglobinuria usually happens in the children, although it's a rare disease. and it happens mainly post-virally. This indicates that it is intravascular. And how I remember that which antigen is involved, I usually remember with the P. Paroxysmal starts with P, so it is the P antigen against which the the antibodies are targeted. And paroxysmal makes me understand that instead of IgM, it is an IgG antibody, but it is biphasic, that it is activated at it is active at both cold temperature and higher temperature. So coming to the diagnostic workup, we have to do a little workup before we say that this patient is suffering from immune hemolysis. The clinical diagnosis is based on the triad of the patient is anemic, so suffers from failure and fatigue. Because of the indirect bilirubinemia, there is jaundice, and the patient may present with splenomegaly. The gallstones and cholecystitis can occur if the condition is chronic. The initial lab investigations will show that the patient is anemic, having low hemoglobin, and the corrected reticulocyte count is high. And the indicators of hemolysis will be present. For example, unconjugated bilirubin will be high, LDH will be high, and haptoglobin, which binds with the hemoglobin, free hemoglobin, that will be low. In a study which was done, it's an older study, but it indicates that hematocrit was 24% and reticulocyte was 5%. In patients with warm autoimmune hemolytic anemia, majority of them had low haptoglobin, and lactate dehydrogenase level was increased, and the bilirubin was high in these patients. Once there is clinical evidence of hemolysis, one needs to find out the cause of hemolysis, and for this, one needs to do a test which is called direct antiglobulin test to find out that the hemolysis which is happening in the patient is immune. So the red cells which are coated with antibody like IgG or C3d, they are incubated with the anti-human IgG and anti-human C3d antibodies, and the centrifugation is done. That lead to the agglutination, and that makes the basis of positive direct antiglobulin test. It can be done in gel columns or it can be done in the tubes, but any reaction which is more than 1+ should be considered as a positive direct antiglobulin test. And there are several studies which have shown that there may or may not be a direct correlation of the titer of the antiglobulin test with the hemolysis which is happening in the patient. The next step is, once immune hemolysis is confirmed, next step is to find out the diagnosis, that what is the type of autoimmune hemolytic anemia. As I've said, there are 4 types of autoimmune hemolytic anemia. So one needs to find which is the type, because the management of the various types is completely different, and the transfusion problems which happen are also well defined in the various types of autoimmune hemolytic anemia. So first, taking up the warm autoimmune hemolytic anemia, the first step is doing polyspecific direct antiglobulin test, which will be positive. And it shows that the results shows that about 67% of the patient will have IgG plus C3d. The 20% of the patient have IgG only, and there will be 13% of the patient who have complements only. The next step is to, if an autoantibody is present, then then we elute these autoantibodies to find out if an specificity can be established for that. So what we do is we add elution buffer to the red cells which are coated with antibody. That these antibodies get separated, and then they are tested against a panel of cells to find out the specificity of these antibodies. And if the antibodies if the patient has produced a lot of antibodies, then the free antibody in the serum will also be present. And in that case, not only the direct antiglobulin test will be positive, but the red cell antibody screening will also be positive. And these usually reacts against all panel cells. So one is familiar with that when you typically check them against these panel cells, screening cells 1, 2, 3, or 1 or 2. Usually you don't have a reaction at the room temperature, but the reaction at 37 degrees centigrade and the after the addition of the Coombs reagent is positive. So typically the reaction is uniform and is reactive with all panel cells, which indicates that autoantibodies do not have any specificity, but they are broadly acting against all type of antigens. There are certain problems that may happen while we are doing serological diagnosis of warm autoimmune hemolytic anemia. One is when the doctor says that the patient is having warm autoimmune, but the direct antiglobulin test is negative. This can happen if the antibodies which are present are of IgA or IgM type, or if it is drug-induced autoimmune hemolytic anemia, or there's the clinical detection of the limit of detection of direct antiglobulin test is around 500 antibodies on the red cells. So if the less number of antibodies are present, the direct antiglobulin may be negative. The second problem which can occur is the presence of IgM agglutinins, which are reactive at 37 degrees centigrade, and these need to be removed using DTT or other reagents before we can proceed with the further workup. The third problem which can occur is the presence of alloantibodies, which becomes very important for from the transfusion perspective. If the patient has a history of transfusion in the past 90 days or patient has pregnancy in the past 90 days, there's likelihood that beside the auto, the patient has allo as well. So what do we do in that case is we do certain absorption studies. For example, if you see the first picture, the red cells are coated with autoantibody, but the green ones are the allo, and the allos are also present. So what we do is in the next step, we do a gentle heat elution with 56 degrees centigrade that will remove the autoantibody from these red cells. And this is followed by a reaction of these enzyme-treated red cells, which are the patient's own red cells and patient's own serum. And you react these, and that will lead to the absorption of these autoantibody on the red cells and the removal. Once you centrifuge, these red cells, which are coated with autoantibody, will be removed, leaving the alloantibody. And this is important for us because when the transfusion is required, we have to give antigen negative blood to the patient. We need to know which alloantibody is this one. So the adsorb serum, autoadsorb serum should be tested for the common clinically significant antibodies like RH, MNS, Cal, Duffy, and KIT, so that it should be determined which antigen negative blood needs to be given to the patient. Auto usually has no specificity, as I've said before. So when you are selecting red cells for transfusion, there may be problems with ABO and RH if IgM antibody is present. Otherwise, typically in case of autoimmune hemolytic anemia with IgG, usually there are no problems in ABO and RH typing. The identification of allo I've just discussed, and if allo is present, then antigen negative red cells should be given. And in case if the autoantibody is also showing a specificity, then antigen negative red cells against auto should also be given to the patient. Next, we come to the serological diagnosis of cold agglutinin disease. So cold agglutinin disease is defined as when the monospecific direct antiglobulin test is strongly positive for complement fragment C3d, and the titer is 64 or more than that at 4 degrees centigrade. And typically, the peripheral blood film showed autoagglutinates, which is typically seen in case of cold agglutinin disease. When you do serology, either you use the columns, gel columns, or you use the tubes, you get a C3d positive reaction. And this should be reactive at 30 degrees centigrade for it to be pathological. That is, it should have a high thermal amplitude. If there's low thermal amplitude, then usually the cold agglutinins are benign and they should not be considered as a part of cold agglutinin disease. The titer may be more than 1000 at 4 degrees centigrade. But now we know that the titer are not that important, but the thermal amplitude of the antibodies are more important in causing hemolysis, and they should be considered as pathological. Typically, the sample should be collected at 37 degrees centigrade, or it's better if you you use the lavender top EDTA plus bottle for collection of the blood. It may be centrifuge. It may be kept at 37 degrees centigrade for 15 minutes so that the cold agglutinins do not get activated. For chronic cold agglutinin disease, serum electrophoresis or immunofixation will show IgM monoclonal gammopathy along with the kappa light chain restriction. There may be some problems that may happen with cold agglutinin disease when you are doing the serological workup. The autoantibody usually has big I or little I specificity, but usually this is of academic interest only. Rarely mask the allo, so this is good part of it. For the selection of the red cells for the transfusion, if the agglutinates are causing problem in ABO and RH typing, then pre-warm technique usually take care of that, and you are able to do correct typing in case of cold agglutinin disease. Just like warm, autoimmune, you need to identify the allo, which is very important from the transfusion point of view. And if allo is positive, then antigen negative red cells should be used for the patient. Typically, the blood grouping reaction looks like this, but once you do pre-warming, the reactions will become clear. For example, in this case, it is a group B positive, and the autocontrol is positive, which is invalidating the result. If it happens like this, it means that more work needs to be done before you will be able to identify the blood group of the patient. Then the serological workup of paroxysmal cold hemoglobinuria typically requires a test which is called Donat-Landsteiner test. In this test, we take 3 sets of tubes, where one is of the patient's serum, the other is the control serum, the other is we add patient's serum along with the normal serum to add as a source of complements to the complement to the patient's serum. And then this is incubated with the red cells of the patient. And usually when you incubate these at the freezing temperature or at the body temperature, no hemolysis happens. But as I've discussed in the pathophysiology, that when you freeze these at 0 degrees centigrade, that means IgG gets activated, bind with the red cells, and when you heat the samples to 37 degrees centigrade, hemolysis will happen. So incubation at low temperature and then high temperature will activate and lead to the hemolysis, which will happen in the patient's tube and in the mixed serum. This is the basis of Donat-Landsteiner. Usually, in case when the transfusion is required, patient can receive random donor red cells. We don't screen for P antigen, but if the patient is not responding to the transfusion with random donor red cells, then P negative red cells are required, which usually becomes very difficult to find a blood with P negative antigen. Then we have mixed type autoimmune hemolytic anemia, which constitute around 8 to 9% of all the types of autoimmune hemolytic anemia. Here, the patients have both IgG and IgM. But unlike warm antibody, warm autoimmune hemolytic anemia, this IgM has a higher thermal amplitude and it is active at 30 degrees centigrade. If elution studies are done, IgG will be recovered from them, and autoabsorption need to be done not only at 37 but also at 4 degrees centigrade to remove all the autoantibodies. So a specificity of this of the warm is broad, just like the warm autoimmune hemolytic anemia, and that of the cold antibody is similar to cold agglutinin disease, that it is big I or little I. When you need to consider for transfusion, you have to the serological workup which you do for cold as well as warm needs to be taken care of in order to remove the IgM and the IgG antibodies in order to identify these antibodies. So both work need to be done. Lastly, we come to the drug-induced autoimmune hemolytic anemia. This drug-induced immune hemolytic anemia have various models. One is the drug adsorption of penicillin. Here, the penicillin is, or the drug is simply adsorbed on the surface of the red cells. The antibody is actually targeted against the drug and not against the red cells. But these red cells, which are coated with antibody, are hemolyzed. They are removed by the spleen, and they undergo extravascular hemolysis. The second model is that of immune complex formation. For example, the drug classical example is that of quinidine. Here it is the immune complex along which have the C3 and C3b, which is they activate the complement system. And the red cells having these receptors, they bind to these immune complex along with the drug, and that lead to the intravascular hemolysis. And here this happens inside the blood vessels. The third type of drug-induced immune hemolytic anemia is that of methyl dopa. Here, the antibody is directed against the antigens present on the red cells, and these red cells are destroyed within the spleen. And this type of immune hemolytic anemia is indistinguishable from warm autoimmune hemolytic anemia. Clinically, it looks like the same. I'm sharing you the algorithm that is given by the American Society of Hematology, which tells you how a patient with autoimmune hemolytic anemia should be processed within the lab. If there's evidence of hemolytic anemia and direct antiglobulin is positive, then this means that the patient is suffering from autoimmune hemolytic anemia. So if the patient has high IgG only, this indicates the patient has warm autoimmune hemolytic anemia. But if the patient has complement plus minus IgG, then one needs to do the antibody titer. And if this is less than 64, then it is a benign condition, insignificant cold agglutinin. But considering that the antibody titer is 64 or more, that indicates that this is significant. And the patient should be either suffering from cold agglutinin disease or mixed autoimmune hemolytic anemia, depending upon if C3 is present all by itself, it is cold agglutinin disease. But if it is present along with the IgG, it is mixed autoimmune hemolytic anemia. The patients who have DAT positive, which is the complement one, and they are having typical feature of hemoglobinuria as well. And the clinical diagnosis is that of paroxysmal cold hemoglobinuria, should be tested by a Donut Landsteiner test in order to diagnose these patients suffering from paroxysmal cold hemoglobinuria. As I said, that these autoimmune hemolytic anemia can be secondary to an underlying disease, which may be a lymphoma or it may be an autoimmune disorder. So we need to diagnose the underlying pathological condition as well. And for that, a number of tests are required depending upon the initial clinical diagnosis. For example, if it is low-grade lymphoproliferative disorder, then one needs to do the flow cytometry, and it should be ordered for all adult patients with warm autoimmune hemolytic anemia. The second is about 30% of the patients who have autoimmune hemolytic anemia, they have venous thromboembolism as well. So D-dimer test should be done, and if it is elevated, then these patients should undergo lower extremity Doppler studies or plus minus CT scan of the chest, if considering if thromboembolic disease is suspected. Rheumatological diseases require autoimmune panels, and if it is a lymphoproliferative disorder, one which is a clinical diagnosis, then one needs to go for bone marrow aspiration, biopsy, CT scan of the chest, abdomen, and pelvis to rule out a lymphoproliferative disorder. So in summary, autoimmune hemolytic anemia is a rare condition, but it is a life-threatening situation. And usually it requires a lot of workup in the blood bank before a compatible blood can be defined for a patient. It has various subtypes, which are cold, warm, mixed, and drug-induced. It may be primary, but secondary to an underlying disorder, which becomes very important as a part of workup of an autoimmune hemolytic anemia. And serological workup is basically based on the positivity of direct antiglobulin test, which is the first and the very basic step in a patient with hemolysis. And once this is positive, one needs to do monospecific direct antiglobulin test. These patients may require elution studies if one is interested in finding out the specificity of auto. But more importantly, alloantibodies, which complicate the picture, needs further studies, which are the autoabsorption studies that are required to get rid of autoantibodies and to establish the specificity of alloantibodies so that antigen negative blood can be arranged for the patient. Sometimes blood grouping and arranging compatible blood units becomes challenges, and in that case, the least compatible blood is issued for the patient because it's more important to transfuse a patient if life-threatening anemia is present rather than to deprive the patient of blood in search of a compatible blood unit. And that is, but when such a blood is issued, good communication is required between the clinician and blood bank, and the clinician and the transfusionists need to be watchful of any increase in hemolysis that may happen with blood transfusion of in these patients. So these are some of the things which I think are important from the hematological point of view for us to know as practicing physician and as a hematologist working in the blood bank, how to deal with the serology or the serological diagnosis of the patients who are suffering from autoimmune hemolytic anemia. Thank you so much for listening to me and providing this opportunity to me. Thank you so much.
Thank you, Dr. Bushra, for such a comprehensive talk. Dr. Ansar Zhalyalov from Moscow, Russia is our next speaker. He has done MS in medical physics from Moscow State University and completed PhD in physics and molecular biology from Moscow. Title of his talk is Digital Imaging and Artificial Intelligence in Hematology, Technology and Opportunities. Over to Dr. Ansar.
Assalamu alaikum. Thank you very much. My name is Ansar Zhalyalov. I am from Celly.AI company. I will start my presentation with some terminology. What's the difference between artificial intelligence, machine learning, and neural networks? Artificial intelligence is a set of algorithms that try to mimic human intelligence. So this is a very wide range of algorithms. For example, enemies in computer games. Machine learning is one of the artificial intelligence algorithms that has ability to improve the algorithm's quality based on learned data. For example, spam filters. And finally, neural networks is a class of machine learning algorithms that try to model in a very simplified form, try to model human brain processes. For example, image detection. About artificial intelligence progress. 1950, Can Machine Things asked Alan Turing, the main ideologist of artificial intelligence. And after that, there started period of publications in the field of artificial intelligence, but the real practice effect started only in 1991 when the internet era started. A lot of AI-based software became to developed and implemented. In 1997, Garry Kasparov, the world top chess champion, was defeated in a match by IBM's Deep Blue algorithm. In 2012, Google's deep learning recognized 10 million pictures of cats from YouTube, and step by step, AI algorithms became better and better, and in 2015, the error rate of AI algorithms in image classification became superior with humans. And there started era of implementation artificial intelligence algorithms into the real world. So AI replaced humans in classical in conservative tasks. For example, autonomous cars, Tesla and Waymo. What about medicine? In 2018, FDA, the American regulator, started to clear AI-based products. The most of the products is based off image analysis, X-rays, computer tomography, mammography, and the number of cleared application is growing. What about hematology? What hematological diagnostic tests is based on image analysis? This is microscopy. And artificial intelligence is the future of microscopy. Why? Because manual microscopy has a set of problems. Lack of qualified staff, lack of standardization, inattention, fatigue, and high labor costs due to non-scalability of manual work. 600 million blood smears are reviewed annually in the world. 100 million of them are already reviewed automatically with AI-based systems, Cell Vision and West Medica. And the only one problem of such systems, their price. The solutions are very costly, few $100,000, and the solution works only in a segment of very large laboratories. And we have developed a very accessible solution for AI-based automation of microscopy. The solution consists of an iPhone, a microscope adapter, and the mobile application. How the solution works? Technician mounts the smartphone to the eyepiece of a microscope, and the application automatically, using neural networks, detects and classifies the cells in the slide. I will show a brief video. This is a microscope. Technician connects the mobile phone to the eyepiece of a microscope, moves the slide, and the application instantly detects, counts, classifies all of the objects in the slide. Also, application makes a digital copy of the slide. And after the test, specialists go to the website, no need additional applications, just web browser, and on the test page, he can review the scanned slide, he can make annotations, use it for collaboration, and he can review the results of AI-based image classification. So the application automatically pre-classified the cells in the slide, and the specialist just check and save the final report. What the laboratories get? Greater speed, because slide analysis up to 10x faster. Highest quality, because AI is trained on the experience of professional pathologists. And ultimate efficiency, because now microscopy tests could be performed by low qualified staff. Supported tests, we started from hematology, automation, white blood cell, red blood cell counting, malaria, detection and counting, and step by step we adding new tests into the software, because for the neural networks, no matter what kind of tissue to analyze, just prepare a data set. This is example of clinical validation, malaria parasitemia level counting in thin film, comparison between 3 experts and the software, and the application analyzes slides 8 times faster than human experts with the same level of accuracy. So main features: automation to replace specialists with technicians, quality control to use artificial intelligence as second opinion, LIS integration and digitization. And moreover, microscope became a slide scanner, which is very useful for collaboration, for telemedicine, for documentation to store slides in the cloud storage, and for education to scan teaching slides and share on tumor boards or with students. And finally, hematologists can make real-time collaborations to share their field of view with remote specialists. Thank you very much.
Thank you, Dr. Ansar, for opening new doors for diagnostics. Our last speaker of this session is Dr. Mohandas Narla from New York, USA. Dr. Mohandas' research career span over 40 years, in which he has largely focused on red cell function in health and diseases. At present, he is a vice president for research at New York Blood Center. Today, he will be enlightening us on membranopathies, frequently missed diagnoses. Dr. Mohandas.
Thank you so much. Thank you for a very kind invitation, and good afternoon to all of you. And I'm going to, next 20 minutes or so, discuss with you red cell membrane disorders. And in this regard, I'd like to thank my colleague, Pat Gallagher of Yale University, for helping me with some of the slides. Okay. The human red cell is about 8 microns in diameter. And but when it goes through the spleen, it has to go through endothelial slits separating the splenic cords from the splenic sinuses, where the endothelial slits are only about a micron to half a micron wide. And so really, it's very important for the red cells to undergo this extensive deformation as shown on the right-hand side. And if the red cell is not able to deform, it will be trapped in the splenic cords and destroyed by the spleen. So spleen is a very important quality control organ for the human red cell. And over the last number of decades, we really have a very good understanding of the structural organization of the red cell membrane. And it consists of basically 2 types of proteins. One, what's called transmembrane proteins or membrane proteins, which are embedded in the lipid bilayer. And these are basically transport anions and cations and all sorts of, and also importantly, in terms of the red cell, what we heard before, they also carry all the blood group antigens on the surface of these membrane proteins. This membrane protein complex is then linked to what's called a membrane skeleton, which comprises of major components are alpha and beta spectrin and protein 4.1 and actin. And what I'm going to show you is that mutations or defects in any of these proteins can lead to red cell membrane disorders. The major disorders I'm going to discuss this afternoon are either due to membrane structural protein defects, which are hereditary spherocytosis and hereditary erythrocytosis, or membrane permeability defects, which are hereditary xerocytosis and hereditary hydrocytosis. And in these cases, the volume regulation of the red cell is compromised. In terms of the membrane structural defects, the most common is the hereditary spherocytosis, and this occurs in all racial and ethnic groups and common in Northern Europeans. Suppose incidence of 1 to 2,000 to 1 to 5,000, but maybe more common. The reason for this is in some of these mild cases of hereditary spherocytosis, the diagnosis is made very late in life when people come up with gallstones. And the inheritance pattern of hereditary spherocytosis is dominant in about 66 to 75% of the cases, and non-dominant inheritance in about 25 to 32% of the cases. And there have been multiple reports of fatal cases due to severe hereditary spherocytosis. In terms of the presentation, it's present as hemolysis and related complications with anemia, jaundice, splenomegaly, fatigue, pallor, gallstones, and crisis. If you make a blood smear, you can see spherocytosis on smear, and because of the anemia, there's reticulocytosis in these patients. And there's positive family history in 2/3 of the patients, and about 1/3 of the patients, the mutations are de novo, and you really don't have a positive family history. But what is very important is if there is a family with HS and the baby is born, it's important to monitor the baby in terms of the development of anemia, because anemia is not present at birth, but develops over the first 2 to 3 weeks of life. In terms of classification of hereditary spherocytosis, basically that it could be very mild with hemoglobin ranging from 11 to 15 with low retic counts and with bilirubin of 1 to 2 and few spherocyte. And then there is moderate expression where the hemoglobin can be between 6 and 12 and retic counts are greater than 8% and bilirubin of 2 to 3 milligrams per deciliter and numerous spherocytosis. In very severe forms, the hemoglobin can be at between 6 to 8 with retic counts greater than 10% and bilirubin greater than 3. And in this case, the spherocytosis are very, very obvious on the blood smear. We have known a lot about the molecular basis for hereditary spherocytosis. And in terms of the mutations in ankyrin or alpha or beta spectrin, which are component of the membrane skeleton, will lead to decreased linkage between the membrane skeleton and the lipid bilayer. And as a result, there is membrane vesiculation, loss of surface area due to uncoupling of lipid bilayer from the membrane, resulting in generation of spherocytic red cells. And if people are interested, there's a reasonable review article published a number of years ago describing these various red cell disorders in blood in 2008. So in terms of laboratory characteristics of hereditary spherocytic red cells, as I said earlier, there is spherocytosis on smear, anemia, reticulocytosis, increased RDW greater than 14, and slight decrease in normal or slight decrease in MCV. And the important thing is that if you can look at the MCHC, it's elevated because the red cells get dehydrated as they lose surface area. And the classical test is increased osmotic fragility. Because the red cells are losing surface area, they exhibit increased osmotic fragility. And there's a new test called, because I heard earlier about flow cytometry and all, there's also a reasonably well-established technique where you can label the red cells with ethylene maleimide, which binds to band 3. And because there's loss of surface area, there's decreased EMA binding, and that's being routinely used in a number of laboratories in the Western countries. And another way to, very nice way to diagnose this is called osmotic gradient ectocytometry. But really, this is a more, the machine is quite expensive, and I think EMA binding, because most people are flow cytometry, I'll recommend the EMA binding test more than osmotic gradient ectocytometry. And clearly nowadays, a lot of people, because of the sequencing and all, we can easily identify. There's a panel for red cell mutations that can be used if it's available to validate the molecular basis for hereditary spherocytosis. Why is making diagnosis important? It is to guide appropriate therapy, which in this case is splenectomy. In severe case of hereditary spherocytosis, splenectomy actually increases the hemoglobin to near normal levels. And also because there is splenic sequestration crisis, and also in terms of parvovirus infection is very important, because these children are anemic already, and they get parvovirus, they can really, the bone marrow shuts down and the hemoglobin can drop, and there are a number of cases of reported death due to parvovirus infection in patients with hereditary spherocytosis. And also, if the cases are severe, it'll be important to make diagnosis so that you can make the parents aware of the genetic cause. And also in terms of future pregnancies and diagnosis and expected management of mothers. The second most common red cell membrane disorder is hereditary elliptocytosis. Again, just like HS, you have various clinical presentations ranging from mild, where all you see is elliptocytosis in the smear, but there is no anemia or the normal hemoglobin levels. Again, just like in HS, you have moderate hemolytic hereditary elliptocytosis and also severe forms of hereditary elliptocytosis. And in fact, I am aware of a number of hydrops fetalis due to very severe mutations in elliptocytosis. In terms of the blood smear, you have elliptocytosis about 25% to 95%, and there is red cell fragmentation on the blood smears and severe anisopoikilocytosis. This is particularly common in African population with prevalence approaching 2% in West Africa. And the idea is that having a hereditary erythrocytosis offers some protection against malarial morbidity and mortality. Most of these red cell disorders, in fact, including not only membrane disorders, but also hemoglobinopathies and G6PD deficiency, are thought to be evolved because of protection against malaria. That's why the frequency of red cell disorders is very, very high globally. And in fact, about 1 in 6 human beings have some form of red cell disorder. They're not severe and things like that, but they do offer protection against malaria. There's a incredible selection in human genetics for mutations that offer protection against malaria. Again, in terms of smear, as I said, in non-hemolytic HE, all you see is elliptocytic morphology, and these people are near normal hemoglobin levels. But in the severe cases, you can see how fragmented the red cells become, and these are the fragmented cells are the ones that are removed by the spleen during circulation. We know a lot about the membrane protein defects. Again, these alpha spectrin defects constitute about 65% of the mutations in elliptocytosis, beta spectrin defects about 30%, and about 5% are due to protein defects. The point I'm making here is all the structural proteins are the mutations that cause either hereditary erythrocytosis or hereditary spherocytosis. In this case, in contrast to HS, where the defect is due to the linkage of the lipid bilayer to the membrane skeleton, in elliptocytosis, you really have defects in the skeletal protein itself that weaken the interaction between these components, and that leads to membrane fragmentation and elliptocytosis. As I said earlier, the travel through the spleen is very risky for both HS and HE red cells, and really the splenic trapping and decreased lifespan of the red cells is the major cause of hemolytic anemia in these inherited red cell membrane disorders. So in terms of management, splenectomy results in significant increase in hemoglobin levels, decreased reticulocytosis in individuals with moderately severe and severe anemias. And the big thing to watch out is overwhelming bacterial infection and thrombosis are long-term risks after splenectomy. So although originally people thought splenectomy is benign, it turns out that it's not that benign at all. And this thrombosis and overwhelming bacterial infection is something that needs to be carefully followed following splenectomy in these individuals. And due to increased awareness of late complications of total splenectomy, in some centers in various countries, partial splenectomy is being used to decrease the severity of anemia, especially in children, while retaining residual splenic function. So that's something to consider in children with very severe anemia, so that you do partial splenectomy. Clearly, over time, the spleen grows back, but at least for the first 10, 15 years of life, they'll have some immunological function from the spleen. The last things I'm going to talk about is membrane permeability defects. And one is called hereditary xerocytosis. And in contrast to HS and HE, these membrane permeability defects are much rarer than the other two diseases. Again, hereditary xerocytosis is autosomal dominant. Anemia is mild to moderate. There are target cells, discocytes, and stomatocytes on smear. The characteristic feature is because these cells lose water, they have increased MCHC. And because they're losing water, they're in contrast to hereditary spherocytosis, where increased osmotic fragility, these cells have decreased osmotic fragility. And the only problem is not the anemia, but the propensity for severe iron overload in these patients. And in fact, there are a number of cases reported because it was misdiagnosed. There is iron overload with cardiac failure and death in the late 20s to early 30s. And the treatment is supportive. And in contrast to hereditary spherocytosis and erythrocytosis, you should not be splenectomize these patients because splenectomy is very deleterious. And in fact, the thrombosis is a big problem following splenectomy in hereditary xerocytosis. Again, we really have, over the number of years, we really understand exactly what the molecular basis for the hereditary xerocytosis is. And this is a mutation of protein called PASO1, which prevents the red cell from maintaining its normal volume. And by losing water through this channel, actually the red cells become more and more dehydrated as they circulate. And in terms of the clinical features, the inheritance is autosomal dominant. As I said, mutations in PASO1 account for the largest number of cases of hereditary xerocytosis. And there's increased MCHC, normocytic with elevated MCH, and decreased osmotic fragility. The clinical treatment is splenectomy is not beneficial and may be deleterious. And in fact, people recommend against splenectomy for sure in hereditary xerocytosis. Again, like all red cell disorders, there's aplastic crisis, iron overload, and thrombosis. The last form of disease is called, in contrast to xerocytosis, where the red cells lose water and get dehydrated, well, in the case of stomatocytosis, they pick up water and they become overhydrated or increased in cell volume. And in this case, you can see a lot of stomatocytes on blood smears. And again, we now know what the molecular basis for this hydrocytosis is mutation in this protein, RHAG, the Rh blood group protein, is responsible for this phenotype. As I said earlier, the way, at least in Europe and North America, you can easily diagnose all these three diseases very convincingly with this technique called osmotic gradient ectocytometry. But unfortunately, as I said, it's a pretty expensive machine. And since, unless you have a lot of cases of these membrane disorders, it will be very difficult to justify the expense in doing this test. So in terms of summary of red cell membrane disorders, I can say with some confidence that molecular basis of hereditary spherocytosis, erythrocytosis are well defined. The degree of hemolysis and spherocytosis, erythrocytosis is related to the extent of red cell membrane surface area allows, and splenectomy results in amelioration of the anemia. In terms of molecular basis for hereditary xerocytosis, hydrocytosis are still being defined, although in xerocytosis it's very clear PASO1 mutations account for more than 90% of the cases. Anemia associated with xerocytosis is mild to moderate, while it's quite severe in hydrocytosis. And splenectomy is not beneficial and may be deleterious in both xerocytosis and hydrocytosis. So finally, I say with the availability of new experimental strategies and new technologies, many opportunities are available to further clinical and scientific understanding of red cell disorders. And in particular, in our context of Pakistan and India and all, there's also co-inheritance of these membrane disorders with hemoglobinopathies and enzymopathies, which will make the situation more severe. So that's something to be kept in mind as we go along. So thank you very much, and I'll be happy to answer questions in the moderations. Thank you very much.
Thank you so much, Professor Mohandas, for such an interesting and informative talk on membranopathies. We are coming to the end of this session, and this session is open for question and answer and panel discussion.
If there are no questions, I'm Professor Altaf. I would like to ask my colleague, Dr. Ayisha Imran, to give her opinion, any comments on first two cases. Dr. Ayisha Imran, please.
Thank you, sir. Thank you, Dr. Zhalyalov, sir, and the PSH for giving me the opportunity. Okay. So thank you for giving me the opportunity to be a part of this new venture, new experience with the virtual hematology conference. So both the first and the second cases, they were very good researches. I have a few questions from the first speaker, which is Dr. Hina. Dr. Hina, it was a very good research on the efficacy of Rituximab in relapsed and autoimmune, relapsed and refractory cases of autoimmune hemolytic anemia. I have a question that you didn't type any, didn't type the autoimmune hemolytic anemia, because as the recent evidence has shown that the hemoglobin level and the type of the autoimmune hemolytic anemia are they are the predictors of relapse and refractory autoimmune hemolytic anemia. there is no data which shows that which type of autoimmune hemolytic anemias did you include in your study?
Thank you, ma'am, for the
Dr.
question. Thank you so much, ma'am, for the question. I have taken both the cases, including warm and cold autoimmune hemolytic anemia. Basically, we took both the patients. I haven't.
So did you find any difference in the response to the treatment? You haven't mentioned clearly what was the difference in the response in both the types, and even the third type, if you took any mixed types.
No, sorry, madam. I have taken both the cases.
Collectively. Okay.
Yes, madam. Collectively.
So can you you have done the study? Can you give any comment on any difference in the results on both, because there is a clear-cut difference
yes, madam,
in response.
There are studies. There are studies which have given best response in cases of warm or autoimmune hemolytic anemia as compared to cold.
Obviously, this is what I wanted to ask, if there is any difference in your study, or is it the same? So you haven't clearly
due to
mentioned.
lack of data, I have taken both the cases collectively.
Okay.
Okay, Dr. Asha, next one, please. Next case.
Okay. It was actually the data is very good, and the response is, I think, the same as we've seen in the rest of the studies.
Yes,
I have a question from Dr. Zohra as well.
Yeah, ma'am.
Dr. Zohra, it was an excellent study, and we know that the high sensitivity PNH testing is the way forward in the diagnosis of PNH cases. My question is, why did you take the diagnosed cases of PNH? You took diagnosed cases of PNH in which you found 100% results in comparison when you did FLAIR with the diagnosed cases of PNH on other technique like the red cell.
Ma'am, the diagnosed cases were initially tested by CD55 and 59. We actually want to check the clone size, and for comparison purposes, what was the results of CD55 and 59, and what we actually get by testing it through FLAIR. This was the only thing.
So this and you didn't even mention the size of the clone that you got on the study, because it is a very sensitive technique and is able to detect even less than 1% and 0.01% in some cases of high sensitivity testing. So what there was no information on how why did you check? My concept is that PNH testing should be, this type of testing should be done not for the classical cases, but for those cases which are undiagnosed, and patients with MDS who might have PNH clone. So and also I think
all of
some of the cases
cases
with bone marrow failures which are undiagnosed.
Ma'am, you are right. Actually, all of the 8 cases were not the diagnosed one. They are suspected. And previously CD55-59 was negative. So when we done the FLAIR, we actually found that they have a PNH clone. They are suspected, not actually diagnosed.
Okay, they were suspected cases.
Yes,
thank you so much. Thank you,
ma'am. Thank you.
May I have the opportunity to talk with Dr. Saima Farhan? Are you on line or not connected? Dr. Saima?
Sir, she is not
okay,
connected.
I think Dr. Saima Farhan.
Sir, she is not connected at present.
Okay. Next speaker is, I think, Dr. Bushra. I don't have any words to appreciate her presentation. And really, it was a very thorough review of the topic. I would just like to differ on one statement, and that is on a lighter note. The last slide, her last line, she said that we may face challenge in giving blood. I would like to say no, we definitely face very severe challenges. It's not easy. I spend nights and nights. Just on lighter note.
Thank you so much. Thank you so much, Dr. Altaf. I fully agree with you. When such patients come, we are just jumping up and down the blood bank. We know we are communicating to the physician, and it is actually very challenging to arrange a blood product.
Just a lighter load, yes, sir. You are very good.
Not only arranging, but transfusing these patients is a big challenge. I fully agree with you. I don't want to undermine that. Yes, it's a big problem.
Yes.
I must say it's a nightmare when a patient with autoimmune hemolytic anemia comes and we have to issue blood, and especially when she has been or he has been transfused previously. This case will take the whole day, and compared to the rest of 100 cases that you do.
Yes.
Without simple antibody identification cases.
I must say it's not only a problem in Pakistan, I think it's a global problem. I think getting people to donate blood is very hard, and a lot of eligible people are somewhat reluctant to donate, so we face the problem all the time too.
Agree. Okay, next speaker is Dr. Ansar. I must thank Dr. Ansar for a very nice presentation on a very new topic for us. Really, the role of imaging and artificial intelligence is increasing day by day in almost every branch, and hematology is no excuse. Although we are a little bit behind, but I'm very sure in days to come, we will have a more role of artificial intelligence. I first want to say, the current literature is a little bit not very focused. We don't have a controlled trials. All trials which are published, almost same technicians, same morphologists, they have just given opinion on morphology as well as on this radio imaging. So we have to develop more studies before we take it, especially in cases of leukemia. It's not easy. Maybe it takes many more years, decades before it establishes role in especially hematology, and that too in cases of leukemia. It may be good in simple scanning of slides for normal cases, but it is the future. And I just want to say one thing. Medicine is thankful to all non-medical scientists. I remember from many big names who have played a good role in hematology, especially it will be a news for most of us that a person famously known as Von Willebrand, he was a civil engineer. So we are thankful to our non-medical colleagues that keep on contributing to our science, especially this hematology. Dr. Ansar,
I have to share a small experience of working with an IT team who wanted to develop an artificial intelligence, and they developed a small software on the mobile to detect malaria off-site because of the lack of availability of technicals. So I was a part of this small study. So it was a very interesting experience and very exciting one as well. Seeing detecting malaria on the phone was amazing experience.
It's a good thing, and we should cooperate with all these researches which are going on, and it should be part of our practice as soon as possible, and we should all work on that. It's a new field for all of us. And coming to Dr. Mohandas, really it was an excellent presentation on this the defects of cytoskeleton of RBCs. It was very nice and comprehensive review of common disorders, and really it was wonderful to listen to you, especially from USA. And we are thankful to you for you spared your time for this topic. And unfortunately, it's very simple once we study the slides, once we read in the books. But again, I would like to say, especially in our setup, with my experience over 30 years, it's not easy once you see a spherocytes in a blood smear to label somebody as spherocytes. We have to take a few precautions. Like, for example, if we see spherocytes, the first step is to go for a Coombs test. The patient must be a negative Coombs test before we can jump on. Then there are many books who are still unable to define what percentage of spherocytes, especially the large type of spherocytes, they are necessary before we embark upon these cases. And one thing I would like to share, in most of my experience, we have seen the mild cases. Majority of my patients, they were mostly present in second and third decades. And again, once again, I would like to thank you for a very nice review of cytoskeleton defects, Dr. Mohandas.
Thank you. Actually, as I mentioned, you're right. These parasites are smear. You definitely want to rule out. Earlier, one of the talks talked about autoimmune hemolytic anemia. So, family history is most important because, as I said, that most of the cases are familial. So, you're absolutely right. Anyway, thank you very much for inviting me. It's a pleasure to meet you all, and I hope we'll have a chance to run into each other sometime in the future.
Dr. Sunila, you have some questions from any participants?
No, sir. Just we have to end this session now. Unfortunately, after such learned discussion, this session has to end.
I would like to thank you for very successful as a moderators. Thank you very much. Really for very nice words you have used for all of us. And our prayers for you and your team
it's
to
all
go very
my
smooth
pleasure.
conference in next few days also. Thank you very much. Thank you.
So it's all my pleasure to have such an
Thank you so
honorable
much.
panel
Thank you.
members. Thank you so much. Thank you, sir. Thank you.
Thank you all very much.
Thank you. Thank you.